So like you said, my name is Dave Brodigam. I've been in healthcare for a long time. So I say 40 plus because I don't want to give you the exact number. You can tell how old I am. I am a consultant. I'm an author and an educator. I helped write the CHTM test not too long ago. I've served on lots of AMI committees. I've been a local biomed society, HDMA, North Texas. I've been involved with that for decades. I've written several books. And actually, I've got a thing at 4 this afternoon on biomed and social media. I'll talk more about that. One thing I think is, to me, is interesting. So I have books that are on biomed, which makes sense on biomed, but I have books that are also on World War II, which makes no sense. But that's okay. I'll tell you why. So experience with IT, I did report. I now teach. I'm a professor for biomed at a community college in Dallas, or just north of Dallas. But I did when I worked in health. When I worked at Baylor, I was there 36 years. 15 of it, we were actually reported to the IT department. And so one thing I did learn, since I was a director, I would sit in meetings with all the other IT directors, and I learned a lot about how they operated. And part of that is sitting there, I don't have a clue what those guys are talking about, right? And I'll get to that in a little bit. And so one of the things that we did for our staff, and this is I think before we joined IT, is I obtained A+ certification in Microsoft networking certification, which I'll talk about later. I highly recommend that. The reason I did it for myself, we all have a motivator. You have to be motivated to do something. When I was a tech, I was in a meeting with GE, IT, and in our department, and we were going to do, what's the EKG storage thing GE does? Muse. Thank you. So we were going to do Muse. And I knew computers, I knew how computers work. And so we're obviously talking about all this networking stuff, and I had no clue what was going on. And I was actually embarrassed as a tech not to understand what was going on. I'm dead serious. Literally, I almost turned around after the meeting and registered to do A+, and then did the whole Microsoft certification thing. I started to. That was my driver to get that done because I didn't know, and I should have known, right? So then we did, from there, it's like, well, it's not just me, it's everybody else. So we actually did train our staff on A+ and Network Plus. And then, of course, I like to make this a joke, is I'm also the CIO and CISO of my home network, right? So if the network's not working, my wife says, hey, I can't do this or that. So I make her put in a work ticket. Obviously know how that works, right? So that doesn't, so anyway, so you'll actually learn, right? So if you're hooking up wireless or anything else in your house, it's a good way to get experience, right? It's your own stuff. So the objectives of what we're trying to do, I want you to learn how to better communicate with IT. And I'll talk about some examples of that. Understand more about just how IT itself works, because you'll be able to communicate better if you know why they do certain things. Learn how IT and biomed differ, right? We don't want to just argue about what everybody does. We operate differently for a reason. And then understand what IT needs from biomed, right? I think that kind of completes the circle. So one thing is be interactive. If you got a question, shout it out, raise your hand. I don't have a problem stopping. You know, the only limit we have is supposed to be 60 minutes. We do have some buffer. I've seen a couple run late, so unless they kick us out, we should be fine around 60 minutes. So, and if you have an example of how you're addressing a problem, please share it, right? This is what this is about, is sharing information. So why am I certified? I talked about this a little bit. I've built and understood computers for a long time. I've actually built Macintoshes. I built PCs. I realized I didn't understand networking, so I went to school. And this was even in a, when you think about, we think about networking and computers are new in biomed. Well, in my experience, we were a GE house for decades. Well, GE, back in the old days, Solar 8000s, early Solar 8000s, they were all network. Space Labs monitoring, that was probably networked before that. We're talking early 90s, so you're talking, do the math, 30-something years. Medical equipment's been networked. That didn't touch another network, it was a private network, but that's how long it's been networked. Another thing here is if you're getting trained, why not get certified? So I'm a big believer in certification of any level, obviously all biomed certification, but IT certification. You need to get the education, right? You're going to get some type of education, whatever way you get it. Well, if you got the education, just get certified. I'm a big believer in that. If I'm presenting my business card to somebody and I've got some credentials on there, it shows an assumed, and I'll use that word loosely, an assumed amount of knowledge, right? If I don't, then you kind of, if somebody has A plus, Network plus, or something else on their card, then you kind of know where you can talk. Otherwise, they might not understand it. So I think that's a starting point. Just do it. One thing I've noticed, when I worked in the hospital, and this was since 7 years now, I was a director, we required all senior BMEDs to be CBET certified. You had to be CBET certified before you became a senior BMED. That was our incentive, right, to get people certified. So I've seen other people start doing that. And I've actually seen some people in the DFW area that are requiring CBET or IT certifications, which I thought was interesting, to actually go to the BMED level 2, right? So I think it's going to be happening. It's not just Dallas, Fort Worth. I'm sure other people are starting to do this also. So why do we need to work with IT? Well, this number will vary a lot. When I led Baylor 7, 8 years ago, I think we were 25% of our medical equipment was networked. I'm talking all biomed and all imaging. Most imaging, I'd say 99% of it is networked somehow, right? And then biomed is less, but you add it together, it's going to be, for us, it was 25. I think it's getting more closer to 50%. I think I've got a slide somewhere that people are thinking it's going to get a lot higher than that. There's going to be some stuff that's never going to be on the network, doesn't need to be on the network, but more and more equipment, they want data being pulled off it. That's kind of the reason. So obviously, the obvious stuff, IV pumps, the most common thing you're going to have in a hospital. I've actually seen some people that don't have those on a network. The biomeds go pump by pump and upload, which, holy cow, that seems to be a lot of work. Because if you got thousands of pumps, that's a lot of work, right? And like I said, imaging, and of course, patient monitor. What patient monitor other than maybe vital signs? Vital signs is starting to, right? They're adding stuff on there, so you can just instantly record that. Yeah, and here's the slide I was talking about. This was on LinkedIn probably a couple of years ago. Within 5 years, 75% of medical devices sold, so it's sold, maybe not connected, will be somehow connected in the future, right? Now, we know medical equipment lasts forever, so that's one time, you know, the curve's going to take a while, but it makes sense. This makes sense to me. So here's my segue into why do we need to understand IT. So anatomy and physiology. I'm assuming everybody's in biomed or works somewhere in biomed. We've taken some type of anatomy and physiology, medical terminology. Why did we take that? Because we have to understand what doctors and nurses and respiratory therapists are saying, right? It's about building blocks of that. So we learned about the structure of the body, internal organs, all that type of stuff. Now we can communicate effectively with nursing. Make sense? Makes sense to me. And I like, you guys like Calvin and Hobbes? I love Calvin and Hobbes. So this is one of my favorite cartoons. Here I am waiting for the bus, 11 more years at school to go, then college and maybe graduate school, and then I die. You know, I work until I die. What kind of world is this? You only get 5 years to be a kid. Always like that. So this is something, I don't remember when I wrote this, but this is my segue. So if we're learning anatomy and physiology and medical terminology to talk with nursing and doctors and respiratory therapists, why don't we learn IT so we can effectively communicate with IT? IT is not going to talk biomed to us. They're going to talk IT to us, right? Nursing is not going to talk tech to us. They're going to talk nursing to us. So to me, this is kind of a way, to me, you can reason, you know, I like to use reason. Sometimes it's, why should I learn IT? Well, if I want to communicate with them, I'll do that. And here's a perfect example of this. If you guys have worked in IT, what's an incident? An incident, from my experience in IT, something's broken, right? It's a laptop is broken. Well, it's an incident. Write up an incident and we'll get it fixed. What's an incident in biomed? Oh yeah, it's a sentinel event. I mean, it's bad. Somebody says you got an incident in biomed. Holy cow! I'm securing equipment. I'm writing reports. I'm doing all kinds of stuff. Well, so think about that. You're in an IT department. You say, I got an incident. Okay, write a report. You know, the comms, nothing, not a big deal. Understand, people have different meanings for words, and it's the same word, right? So that's not the only reason, but it's one of the reasons I've seen that's kind of important. So again, bottom line, why don't we learn information technology to better communicate with IT? So what do we need to do? Well, we need to learn new skills if we're going to work with IT, learn from IT and their best practices. You know, we like to think that we know the best of everything, but why not? I actually think sometimes biomed is the best at stealing stuff from other people, right? We beg, borrow, and steal or copy what somebody else is doing. Why reinvent it, right? So IT has got a lot of best practices. Well, then why not use some of their best practices and incorporate them in what you're doing? And then learn from other healthcare, kind of what we're doing in here, right? Learn what other people are doing so I can become better at it. So I kind of laid out a couple things that I would highly recommend that your departments do. So think about preparing for the future. If you're a BMed, then you definitely should get CBET or CRES, right? I think it's important to have the certification. Literally, can you name anybody in healthcare that doesn't have a certification requirement? Lab, respiratory, nursing, almost everybody has some type of certification requirement. Why not do it also, right? Why not add those initials to it? You guys all know we've dropped CLES, right? I mean, because nobody was taking the test in the lab. Well, then on top of that, to me, that's a minimum. You should get one of these. Then on top of that, add A+, Network Plus, and Security Plus. Now, I could drop Security Plus, but that's not a big step after Network Plus, right? Go and get all three of those. So those are all CompTIA. If you're familiar with CompTIA, they're the ones who do all those certifications. If you haven't finished your degree, maybe because you came out of the military or came some other way, then finish your degree in biomed and get your AAS. There were discussions years ago, 10, 15 years ago in Texas, they were going to require certain levels of educational requirements for people to be certified or to be in biomed. That's since gone away, but that should be kind of a wake-up call that maybe I should start preparing for this. And I've seen it's not just us. I saw this when I was working at Baylor. I saw this in respiratory. I think they were starting to change the education requirements for all the people being respiratory therapists. I think it was going from a 2-year to a 4-year degree. So look to see what's on the horizon and start preparing for that, right? You get this stuff overnight. And then if you're interested in getting into management later, then get your CHTM, which is Certified Healthcare Technology Manager, and then ITIL, which I think I've got a slide on ITIL to talk about. And then again, if you're interested in management, get a bachelor's degree. If you're a manager, you're managing people, not equipment, right? A tech, I love being a tech, and now that I'm a professor, I forget how much fun it was being a tech, but it's totally different. It's like 180 out, right? I love repairing equipment, managing people. I think I like better doing equipment, but it's okay. I mean, everybody's got their pros and cons, but you have to have the education to do it. And to me, a business degree helps you manage a department much better and understand how it works. I would highly recommend all my managers to get a business degree if they wanted to continue on. And you could argue, if you look at anything, if you ever look for a director position, they almost always say it's at least a 4-year degree, if not a master's level degree. Get prepared, get those things out of the way, right? So you can't get these things overnight. Well, legitimately, you can't get them overnight. I could print you a degree, but it's not going to be legitimate. So learning foundations, so A+, if you're not familiar with that, hardware, operating system and troubleshooting, networking, hardware, mobile device security, and operational procedures. A+ is similar to CBET, to where you have continuing education units. It goes like 3 years, something like that. I know you guys don't think I'm that old, but when I did my A+, they didn't have a deal where you had to redo it ever so often, so I'm like legacy in that. I think my CBET was too, but so nowadays you've got to do CE credits, probably similar to what we do CBET, but it's highly recommended. I think it's still 2 tests, one's hardware, one software. The hardware one to me theoretically was easy. The software to me was always the harder part, but you have to pass both tests to get your A+. Highly recommend you do it. The other thing I don't have on the slide, if you want to learn more about computers, which you should, because so much stuff is computer-based in biomed anyway, build a computer. I mean, literally, it's all you're doing is buying parts and sticking it in a box and loading software. And software is the hardest part. It's fun. It's usually less expensive, and you can customize it any way you want to. But it's a great way to learn. When I did my A+, we built a computer, and that's a great way to learn all the components. Other foundations I talked about, networking. So Network Plus, the concept, infrastructure, operations, security, troubleshooting and tools. Security Plus, so threats and attacks, technologies, architecture, risk management. Those are all of these are good to me for BMEDs. Now this is the one I talked about, ITIL. So remember I talked at the beginning. So I would sit in meetings in IT. I was the only biomed, or my boss might have been in the meeting too, but we had all these other IT people in the room, and they're talking stuff I have no clue what they're talking about. I just sit there, right? I'm listening, absorbing. And then somewhere in there, they came up, said, we're going to take there's an ITIL test that's going to be held, and the IT department will pay for it if you want to do it. So I looked up what ITIL was. ITIL basically is a certification for people in IT, right? IT, Information Technology Infrastructure Library. And it wasn't going to cost me anything. It's like, yeah, I told my boss, I'll take it. So I took it. I won't tell you what I scored, but I passed. I did pass the test. It was like a 4-week, or not 4-week, it was like a 4-day program and take the test on Friday. So it was fast. But I learned a lot. I learned ITIL basically is like best practice for operations management of an IT department, right? That's kind of the better information technology infrastructure library. Makes no sense. It's just best practice for IT. But if you can understand that, if you take it, you're going to understand. I highly recommend this for managers. Techs can do it if you want, but managers, you should do this because now you can understand why is IT saying this? Why is IT requiring this? Why is IT doing this? Well, it's all based on this. Probably every high-level IT department should be following this layout. Additional learning. Most of you should be familiar with these, right? So you've got webinars from Amy. Obviously, the TechNation webinars. Anything from me, it's going to be awesome, right? You got to watch what I do. And Ben Singh, obviously, anything from Ben Singh is going to be really good. You got to watch him. 24/7, and just vendors. There's a lot of vendors who are doing webinars now. And I didn't put on here. Well, I did put YouTube, but there's a ton of podcasts now. Holy cow! I'll talk about that at my 4 o'clock thing on biomed and social media. There's a ton of stuff out there now on ways you can just get more information. Obviously, trade shows. You can start learning. I still struggle with IT, a lot of things, but one of my theories on IT is I read something, and you could argue a lot of stuff like this. I read something, yeah, I don't get it. I'm going to buy something, I'll buy another one, and I'll read this, and then I'll buy another one. All of a sudden, finally goes, oh, now once I've read 3 or 4 of these different ways, now it starts to make sense. So don't get discouraged. It doesn't come easy. IT, I think IT knowledge is unlike a lot of skills. You guys ride a bicycle, you struggle, but you could probably get on a bicycle now and still ride it. You have ridden a bicycle in 20 years. I don't think you can do that with IT. IT, that knowledge just goes away. You don't use it, I think you really do lose it. So you've got to find a way to keep practicing, keep using it somehow to do that, to keep the knowledge going. YouTube is a really big source. And you guys know Justin Barber with Better Biomed. I mean, that's probably the best known source out there. He was going to do 4 o'clock with me also, but he had to leave early, so he's not going to be there. But I'll talk about some of the stuff he does. If you've never checked out Justin and Better Biomed, holy cow, there's 100 videos out there. He really does a great job. And even though I was joking, managing your network at home, that's a great way to learn about IT, right? Because you're doing everything. I don't recommend having your wife put in a service ticket. You do that once and it's funny to you, it's not funny to her. I did put this on, I don't know if it makes sense. So I do have a smart house, sort of, if you want to call it a smart house. So I have all these smart devices in the house. I love all the geeky stuff going on and off. And so one of the devices I have, it says you need to upgrade the firmware on your light bulb. And I'm thinking, what the? A firmware on my light? Yeah, I had to update the firmware on my light bulb. There's some sent there, and it's like, you got to be kidding me. But I did it, but it's like, holy cow. When does a light bulb become that complicated? So I've kind of mentioned this, IT comes slow, right? You're not going to just instantly walk out of this or your A+ or Network Plus and be an expert at stuff. It takes a while. It just, to me, it does. And I think most people I talk to, it just takes forever, right? So just like when you graduated from biomed school, you're not perfect. You can't go out and fix everything in the world. I never, as a BMed, I never felt adequate because there's just too much stuff. And as soon as you think you're kind of catching up, well, then something else comes out. So don't get discouraged. Just keep practicing it and keep working at it. I did want to talk about this from this. Now, obviously, this is from my experience, but I think my feeling always is biomeds didn't quite understand how IT worked. My feeling also was most biomeds think IT is a field service techs. So I wanted to go a couple of slides on how our hospital was set up with IT. In our hospital, I say a hospital with 25 hospitals in the system. So most people know what a CIO, right? They're the chief, right? Chief Information Officer. A lot of people, most people now probably have a Chief Information Security Officer. I've read a lot of stuff that actually people don't recommend. The CISO reports to the CIO. because you can have a conflict of security and cost and all that type of stuff. So sometimes they want that person to report differently. It's not my concern, right? It's somebody else's. So if you don't have a CISO in your IT department, don't worry about it. Hopefully there's somebody who's doing that job. And then of course your vice presidents. Yes.
The role of a CDO, CTO, is in that structure or?
I haven't seen, CTO, I've seen CTO for years talking about that, and I've just never seen anybody, we didn't have one at Baylor. I'm pretty sure we didn't have one. I know we had one guy that in IT that was kind of the technology guru, but I don't think he was called a CTO. He was like the new evolving technology type person. Yeah, I mean, they've been talking about that for like 20 years or something, right? And they said this would be a great role for biomed to get into, and I just never saw it.
Yeah, because sometimes they can filter out, the responsibilities between the CIO, CTO. CTO has the new evolution, and CIO is the owner of the budget. And also this kind of structure is sometimes confusing, when you're talking to a
Yeah. So for here, when I worked at Baylor, these are the vice presidents we had. So right, CIOs at top, and you had VPs underneath them. So we had VPs of infrastructure. Infrastructure is like your network, right? Could be your UPSs, could be your network closets, could be your data servers, all that type of stuff. You had a security team, you had a help desk. Our field support also did telecom, right? So IP phones, or they didn't do nurse calls. I've seen some IT that considered nurse call telecom, which kind of makes sense to me. And then we had project management office, PMOs, and then we had an application team. And so the next slide is a pie chart, and I want to give you a visual representation of how big each group was in reference to biomed, right? Because we were part of IT. And so you can see down here, I can't see it from there, it's 9, so biomed was 9%. I don't remember, it's been many years. I think we had 1,500 people in IT, but that counted biomed, so that thing makes sense, like 9% of 150, whatever that number is. Yeah, I think we had over 100 people in biomed, between 100 and 125, something like that. Well, so here's a good reference. Telecom basically was the same size, right? Or I said telecom. So field, there's telecom and then there's field support over here. So telecom and field support added together is bigger than what biomed was. Look at this one. This is the one I think is shocking. We always think about the hardware and the network and the field support people. For us, and this might be the same or not at your hospital, applications was 43% of our staff. And if you don't think about it, well, how many applications do they have? Well, that's why I listed some of these. These are probably a lot of the stuff that you guys have. And then obviously I ran out of space to put all the applications in there. There's probably thousands of them, at least hundreds of them. That's big. It's a big thing that IT has to take care of. And it's not just clinical applications, it's HR stuff. It's payroll, it's all kinds of different things that they do. But I've always liked this slide because it helps give a better picture of how big we are compared to somebody else. I always used to hear biomed should take over IT. Yeah, that makes sense. We're 9% of what the size of IT is. That usually doesn't happen, right? Okay, so let me give you a little bit of background on how we operated when I was at Baylor. So we had an imaging director, and we had a system director, and he had managers. And he had imaging engineers 1 and 2. That's what they called the people that worked on imaging equipment. I was in charge of all biomed, so non-imaging. I was the system director. We had regional directors and managers, and we had BMEDs 1, 2, and senior. Right? I talked about earlier, seniors had to be CBED. And then we actually had a clinical engineering team. So they did database support, project management, and then cybersecurity report. And we reported to the VP of IT, somebody in IT. I think last time we reported the infrastructure. It doesn't really matter, I don't think, where you reported, but they felt that was good. And then we had a consultant come in, and the consultant, the last place he was at, they reported the supply chain, so they changed us to supply chain. That's fine. And usually what you're comfortable with, doesn't matter. I don't think it really matters where you report, right? Reporting to IT, that's awesome, right? You can talk to people, you report to nursing, supply chain, engineering. It doesn't really matter. It's all about communication. Here's one thing that helped me understand, because you've all been in biomed, we've all said you need to find ways to cut costs, which would be my next slide. IT, in my experience where I was totally different. IT one is more project-based, right? So we always think about IT, well, it's desktop computers, stuff like that. We'll go back to the last slide, 10%, 9%. 15%, that's not a lot. It's all applications, it's all this other stuff. So IT, the way they did, if they need to cut costs, they have a governance committee, right? There's these people that sit on this governance committee, so they're going to be high-level people in the system. They're going to decide what projects to keep and cut. So if they come back and says, across the board, we need to cut 10% of our budget. So everybody, biomed, IT, nursing, everybody has to do that. What IT does, it says, okay, so go to the governance committee, says, we need to cut 10% of our budget. Here's all of our projects. And then where do you want to cut the 10% out, right? And we won't do this, and do this, do this. It's not just draw a line somewhere. I guess you add up the money and they have to prioritize it. So the onus is on the governance committee, which I actually thought was kind of neat, right? So you have some buy-in on which projects you're doing or not. You don't just cut costs by finding the more effective one. You can, but for them, it was, you let the governance committee decide that. I thought that was kind of neat. So biomeds, you can't just let equipment lay around unrepaired. I actually had somebody ask me that, said, well, can you not just not repair it? Well, maybe if you have enough of it, but sometimes you can't, right? So you have to figure out what you can do better if you're going to have it. You don't have somebody's going to decide you're going to cut 10%, what are you going to do? It's going to be your decision how to do that. One, you might be able to do less PMs, which really leads to the next thing, which is you could have an AEM strategy, right? So AEM, assuming it's not impacting the reliability of a piece of equipment, I might be able to cut back a PM twice a year to once a year, and equipment still runs effectively, but I've saved, I could do my man-hour count, how much it would take, and then I could save X amount of time, right? So you could add some of those things up. Not always the reason you do an AEM, but sometimes that's one of the reasons. You could also, probably the more effective one is reduce coverage on contracts, right? So if you have gold or bronze or silver, whatever they call those, I'll give you an example. I was fortunate that finance gave me all responsibility for all medical equipment. So lab contracts, OR contracts, all that stuff. Now, I wasn't popular with some of the people, right? OR and lab sometimes. And so one example we did is I would look at lab contracts. Well, we had 24-hour coverage, and yet the lab's not open on a weekend. Why do I have 24-hour coverage? I mean, 24/7, right? So why do and the people I worked with, they actually had a work week, right? So Monday to Friday, 8 to 5, but then they had also Monday to Friday, 7 to 10, something like that, right? So you can choose between packages and become more effective and actually not even decrease the level of service and save a ton of money by just looking at some of those contracts, right? And so that's one of the things we did. Now, one of the things that we also did is, well, other than bringing in-house, that's an easy thing to do, right? Well, theoretically, it's an easy thing to do if you can show the cost justification. One of the things we did with some contracts is we just went, I think Mark did this earlier, run to fail, right? And I know that's not a good word to use. I forgot, did you use a different word on yours? Yeah.
Yeah.
Well, did you use run to fail?
No, we just compared the number of repairs over a period of time before and after we made a change.
Yeah.
Yeah.
So one of the things you can do is, and we did this for a lot, which didn't do a contract. Now I was lucky that I had a huge, right? I mean, 25 hospitals, something like that. So I've got literally a big service bucket. And so what I could do is I would just not do a contract, and I'll see. Now you could do some guesswork. Obviously, hopefully you want to do some guesswork, but I could also I'll just do it, right? I've got enough leeway in my budget to where I'm just not going to cancel the contract, and I'll see if I'm actually paying more money. And if I do, well, then it makes sense to sign a contract. If it's not, then I just save this money, right? So I can absorb that risk, if you want to call it that. And so we use the word run to fail. I think there's probably a better word out there, but I don't remember what it is. But you guys, I'm not going to do a PM. I'm not going to do a contract. We're going to see what happens. Yeah, time material. Yeah. And so this one also was it hit me when I started seeing this. So obviously I worked in IT, but I also had a friend of mine that did consulting in IT. So you guys know what cost of service ratio, that's been around for a while now. So cost of service ratio is, what did I pay for it, how much I pay per year. You could do this literally for anything in the world. So cost of service ratio, and I've heard this from different sources in IT, is 15 to 25% of asset value. And it's typically software only. It's not the hardware. So if you've got some magic software system you're doing, it's going to cost you 15, 20, 25% per year to do that. And if your server goes down, well, that's not included, right? And it's just a software piece of that. Biomed, the normal, the number that's been floating around for decades is 5 to 6%, right? So you add IT, I mean, you add imaging, add biomed, it's usually 5 to 6% of asset value. But it's hardware based on it, right? We didn't really have a lot of software stuff in there. So one thing's literally, this is scaring me to death, sort of. I'm not a director anymore, so I'm just teaching, but it would scare me. That's like, holy cow. I mean, it's not pure math, but if I added 5% and now I'm going another 25%, geez, oh, Pete, that's a lot of money to spend per year. That really concerned me. And a part of that is, right, we got cybersecurity, and now we're adding more and more application support and biomed stuff. So that's one of my big concerns is the biomed cost service ratio is just going to go through the roof. Yes. Well, I've been out of hospital for 7 years, but I'd love to hear people in the field if they've seen if they're tracking cost of service ratio. I track it every year. We would see year to year, we're going up and down. So I don't have the data to show that I went up, but to me, it just kind of makes sense that it had to, right? Assuming that you're paying for that service contract, right? So you might not. I could see people. I mean, so a good example of that is remember when IV pumps were IV pumps because there was nothing to them, there's no net card, there's no drug library. Okay, and then all of a sudden now we get smart pumps, which we've had for what, 15 or 20 years now. Well, there is a server and all that stuff is stored somewhere. Somebody's paying for that. If Biomed's not paying for it, then you're not seeing a cost increase. Well, I pay for that. You know, it's hundreds of thousands of dollars a year. So, yeah, you could start theoretically, yeah, I saw a bump, right? It was a significant amount of time. Keep adding that stuff on. They should monitor you. I've seen more and more vendors coming out with contract requirements to keep your OS up to level. All the other type of stuff that goes with it. So it's going to be more of a creepy thing as opposed to all of a sudden it's way up there that you don't want to get it away. But you might be able to say, this is what's happening, guys. You know, there's nothing we can do about it. Yes.
Are you saying your cost of service internally to keep up with the technology that you're utilizing? You're not referencing the cost from a supplier.
Well, depends on how you define it. I guess.
So my point would be, so if it took that number, that's why I'm asking the question. If you took the supplier, it's $1 million, and your cost is 25%. Well, that's actually a great deal for you because they're not getting their money back for 4 years. So that's fair. The issue is, what are you doing? And are you talking about your cost increasing in order to utilize the supplier's technology?
Now, I guess I'm not sure how I would answer that. Just on the biomed side, 5 to 6% is just, it's what it's costing me to repair it. So not to get too much in the weeds, 5 to 6% is typically an in-house, not from third party is probably 7 to 10, and then OEMs is typically 10 to 20%. Right? That's kind of how they figure out what they're going to charge you. I mean, there's profit motives with it, right?
Right. I'm good with you on the hardware, and I agree with all those numbers. It seemed a little blurry to me. What's that 15 to 25? Is it just internal or is it the supplier?
So the supplier is charging you that. I'm sorry, that makes sense. So if I have $1 million contract, they're going to charge me $250,000, $150,000, $250,000 per year to support that application.
Right.
That makes sense.
Yeah, and I was just going to well, that's kind of fair, but they're not getting the money back for 4 years. So that's not unrealized.
Well, I guess it depends on, I guess I assume I paid the $1 million up front, and then I'm paying an additional 15 to 25% each year. That's how the biomed stuff works, right? I paid $1 million.
That's my question. Okay. I was looking at the stats. You didn't pay $1 million up front. You're paying 25% over 4 years. That's right. But to your point, if you're paying $1 million and then 25 to keep it up, now that is
right. And that's the way I've always done it.
That's what I'm saying.
Gotcha. Thanks.
Right. No, thank you for the clarification.
Sure. No, thanks for the question. Do you have a question?
I was just going to share what we're doing. Comparison, cost of service ratio. That if you have software like you have a software contract with that, and that 25% would be that software contract.
Right. Right.
And then additional support you have to provide instruction. But
True. And you could argue it's debatable on whose responsibility is to pay the contract, right? Because you could say, well, it's an application, so it should be nursing or radiology or something like that. I give you, to me, it's the easy example of IV pumps has been around for a while. It was just thrown in our bucket. So, and I know before I left, I had a major vendor for patient monitoring. We signed a contract to keep our OS and version level of our application support up to date, right? Now, in some, you could go at risk, right? You could go, I'll just go at risk. And whenever I need to upgrade my patient monitoring or whatever, I'll just pay the fee. And I've actually seen several large organizations, they're not, well, they're still doing the smart pumps, but they're not, like we said earlier, they're not doing them wirelessly, right? The biomeds are doing it. It just doesn't sound efficient, but you could do the cost, what it costs to do it and what's it cost to do the infrastructure.
But what does it cost to not do the infrastructure over the next 5, 6, 7 years on those assets and continue to do it manually?
I think that's a great question, because to me, I think pumps are, I think it'd be pretty clear. I mean, you could ballpark, okay, it's gonna take me 5 minutes to do a pump, it's gonna take me 30 minutes to find it, right? And then, it's allowed, so just ballpark it, 30 minutes per pump, I got 1,000 pumps, that's how many hours, my long time labor. And then, what if I just put it on the network? I don't know, somebody said that's calculation.
I've experienced that the board that signs off on capital, because they haven't done the infrastructure ever before, it's a new request, and they're uncomfortable with the request. So they go to legacy, which they've done before and they're comfortable with, and therefore they don't advance the new technology just because. And that's what seems to be so far from today's market, these capital applications behind the blackbird.
Sure. Did you have a question back there? The Philadelphia Eagle guy?
I'm sorry?
Did you have a question while ago?
No.
I was talking
I was
about-
saying, if you can find the pump in 30 minutes, I'm impressed.
Well, I think you can approximate, but you're right.
Unless you've got RTLS and, full on support from
Right.
there's no way in hell you're finding.
Yeah, man,
one
and-
individual pump.
And the point is, you gotta come up with a ballpark for somebody to understand the cost justification, right? So whether you use 30 minutes, 45 minutes, an hour, come up with something that you could at least justify to say, we should do this and not do this, right? Kind of a simple ROI type thing. And so one of the slides is, so what's changed with all this IT stuff that we're doing? Arguably, it's been going on for a while. So what's the new practices in HCM and IT? One is, you can't, hope not, I know we couldn't where I worked, you couldn't just take a patient monitor out like we used to do in the old days. Okay, this ICU 3 failed. I just get another bedside monitor, stick it in there, and we change the name to ICU 3, that works, right? You can't do that anymore because everything's tied together, right? All this stuff in the back is tied together to EHR. Oh, we had to have a huge document on all the procedures we would do if we're just replacing a simple patient monitor. You can't just go in and change, for us, we couldn't just go in and change the name. You had to link it to all this type of stuff. It really complicated stuff. But it made sense. It's just not going to link your patient record to the right person, right? If you don't do it right. When I was a tech, it's been a while since I was a tech, but in the old days, you guys know what a hub is? So a hub was pre-switch, and it's almost, even though you buy switches for a house, it's kind of the same idea. You don't really configure them. And so the old days when I was a tech, I remember the first time I had somebody came to me and they go, I'm in the ER and we just had a patient of mine and we sent him to the ICU and I used to be able to get on the network and I could see him. And it's like, oh, well, one, I was kind of impressed that he knew he could do that. And second, I go, wonder why that's not working. So I go in the closet and open it up and of course it's a rack of stuff, lights blinking all over the place. I wonder what's wrong. I mean, I never looked at something like that. At the time, I called the vendor up and he walked me through some stuff. And he goes, is this light blinking? And I looked and I go, no. He goes, oh, you probably got a bad port on the hub. So I unplugged it, put a piece of tape over it, plugged it into another jack, and it worked. But you could do that in the old days, right? Switches nowadays are configured. You just can't make a simple switch like that. And I think it did it one more time where a whole hub went down. Glad you bought a hub from off the shelf, right? Not from the vendor. literally just overnight plugged it in and it worked fine because there's no configuration. Nowadays, you can do that, but you need to know how to configure the switch. They might VLAN it, they may do a whole bunch of other stuff. So if you don't know how to do that, learn how to do that. That's another important thing that's going to happen. Well, it's happening now. And obviously, I think hopefully most of us know you can't just buy medical equipment, or you shouldn't, and just stick it on a network. There's all kinds of, not just cybersecurity, but other things you've got to worry about before you do that. I've talked about this and some of my other things. I think most of you guys have probably heard. If you think about the big four in just IT in general, Alphabet, you guys knew who Alphabet is? Google, I'm not sure why they chose, that's another name for Alphabet or Google. So Alphabet, Amazon, Apple, and Microsoft, those are the big four people in IT. Well, they've been putting their hands in the medical field for a while. One of the things I've seen is more and more people are, I think I've seen this for a couple of years at least, even hospitals are finding ways to reduce costs, right? So it's costing me money to do insurance, it's costing me money to do this. So why can't maybe I can cut out the middle person. So one of the things they've done is, for example, Walmart is actually starting to they're starting to do stuff for their customers directly. Intermountain Health has also been doing that. They're cutting out the middle person, finding ways to do healthcare directly for them. And then I worked for Baylor Scott and White. They're actually sticking little mini clinics. So Tom Thumb is a grocery store. They're sticking mini clinics inside grocery stores. So people are being innovative to try to find ways to cut costs in this. When I worked for Baylor, they actually bought another hospital system that had their own insurance plan, right? So if you want to cut out the middleman, buy the insurance company, right? Buy the middleman. And that was one way they did it. You guys are familiar with AliveCore? So anybody have an Apple Watch? So your Apple Watch can take your ECG, the new ones can do pulse ox, all that type of stuff. So AliveCore came out years ago. I hope most of you guys, I don't think it's a bad term. I mean, I'm a geek, I'm a biomed geek. I love technology when it works. And I had a friend of mine that was at biomed, and he actually did have a heart condition. And so his doctor says, buy this AliveCore thing. And so you actually put your fingers on this thing, it'll take your EKG, it links to your phone, and you record your rhythm. I thought that was actually pretty cool. I didn't have a heart condition, not that I knew of. I said, but I want one of those because it's geeky, right? I mean, I want one. So I bought one. And so I used it for years. And then when Apple came out with the Apple Watch and do EKGs, you can do an EKG on your watch. I still have it. I just don't use it that much. But that's actually pretty cool. They've actually since, so they've reduced the price down to $79, used to be $99. I think my battery lasted for years. I think I finally put a new nickel-sized battery in there. They've now come out with a 6 lead or 12 lead. And I think you have to do an EKG and then you move it around different parts of your chest to get the other readings. But this is obviously just a single lead, right? You're just using left arm, right arm. So here's an example. This is actually a report from AliveCore. That actually is my ECG. I blocked out my private information, including my age, I think. But that's actually my ECG. That's actually a pretty good recording, I think, right? I mean, it looks kind of like what you'd find in a hospital, right? You've got the header up here, you've got your reading up here, you get all the OS information down there. That's pretty cool. One of the things they also did, which I thought was neat, Apple doesn't do this if I remember right, is they encrypted it and they password protect it. So when I record it, you save it, you put a password on it, then you could send it to your physician or something like that, or you could just save it and see what you're doing time by time. It's kind of cool. Think about it. This has been out at least 7 years, 10 years. It's been out for a while. So I talked about this a while ago. So I'm taking my lead like this, my ECG, this finger, this finger. So somebody raise your hand if you know what lead is that. Anybody know? Don't yell it out. Just raise your hand. Anybody guess? In the back?
Lead one.
How come it's lead one?
What else is that from? What else is that from?
Yeah, exactly. So most people will say is lead two, right? Lead one, lead two, lead three. So see me afterward, you get a free book. So it's neat. I mean, we think it's lead two because of the amplitude, but yeah, it's actually lead one. There's another good reason why you need to know. I don't think we were taught this in anatomy and physiology. I didn't know this was about med. My boss had to teach me Einthoven's triangle. You need to know that it's about med. You're going to troubleshoot. So you go on now with the Apple Watch. So Apple Watch now, we're up to 8 or 9, whatever we're up to now. It not only does EKG, the new ones do pulse ox, It actually does fall detection. So some of you young guys aren't worried about that, but I'm starting to get older. If I fall, there's some algorithm that actually will detect. And I think I've read stuff, probably was a biomed, they're throwing themselves on the ground, trying to get this thing to fail. Well, there's some way it actually knows that you've actually fall. And if you don't answer, it'll call 911. That's actually kind of cool, right? That's kind of cool tech if you think about it. Yeah, so fall detection, there's more stuff in there. It talks about that. It'll actually call. I think there's going to be a lot of stuff in the future. This is an opportunity for us. I used to do a talk on this. I think Dave Scott did one, and I think he's doing another one next door on future technology. Think about all the stuff that can be happening now. You can do EKG from your wrist or from the home, non-invasive blood pressure, pulse ox, glucose monitoring. I think a friend of mine, you take a smartphone and hold it over the glucose thing and take your glucose, right? You do all kinds of stuff. Doctor the patient over the web, right? We call it Zooming, but there's all kinds of other things you can do to connect with a physician. I think, and we already talked about patients going to alternative sources, just like I'll get you. But then the last one was, who the heck is going to take care of this stuff, right? Is it going to be us, going to be IT, or what? Yes.
That's a good question about it. Your organization, if you have a service level agreement with HIT.
Great question. So IT has service level agreements, in my experience, with all their customers. In my experience, biomed never did. It was like, oh, we'll be there as soon as we can. I think that's something we can learn from that. Come up with service level agreements. You don't have to do it, then talk to somebody in IT and they can walk you through it. But, yeah, I don't think we did at the time when I left, but that would make sense also.
I do remember a quick question for you also.
Yes.
So, I mean, all of that is pretty neat and nice, but what do you think the implications of cybersecurity will be into how we will in the future based in?
Well, so that's actually a good question because I love all the geeky stuff and home automation and all this type of stuff, but there's a lot of people that I talk to in healthcare or IT, they don't do anything. And I'm not touching that stuff because it's probably the most.
Yeah, right now, it's vulnerabilities and everybody, I mean, the way I feel is like a lot of, healthcare organizations are sort of panicking a little bit. And it's kind of like a big conversation, how to manage vulnerabilities.
Sure.
At, medical devices, especially when it comes to, patient, as we evolve, right, patient medical devices at home, what that the implication of that's. Yeah, so just curious to see what your thought was on that.
So a long time ago, before we did stuff like this, we did, what's it called? Environmental control for people like who are disabled, right? They can't talk, or they can talk, but they can't move arms, can't move legs. So we actually used to be able to we would design something, they could do a secret puff switch and they could control their environment, hence the environmental control unit. But we would go to their home to set those things up. I don't know about you guys.
Yeah.
I mean, I obviously my home is nice.
Yeah.
There's some people with pretty nasty homes. And so I'll be one of the things I worry about this a little bit. It's like, ooh, the cow. And actually, forget that. What about the infrastructure? I mean, they may live out in the middle of nowhere. They lose power every other day. Well, if I'm on an event or something like that, that's kind of a pretty big concern, right? I have wireless access to be able to do things. So there's a lot of things that we take for granted. If you work in the city that people somewhere else might not have, much less healthcare access, but the infrastructure to work those things.
So I got a question. The thing that we're seeing is since COVID, is all of a sudden these devices are coming out with the cloud. It's a medical device that physically hooks up the patient.
Sure.
So when they walk into the hospital, well, you don't set up the because it goes to the cloud. And then you're like, well, bomb it and do what they need to check the device and make sure it's working. But then you have the ideal is who really owns that because it's going to the cloud. Now you got to have a security way of accessing information and reading a diagnosis on it.
And how secure is the cloud?
Well, the thing is we still own the device when it comes in, it goes to check in your settings.
Right.
But it goes to the hospital Wi-Fi, and then it goes to the cloud, and then the doctor accesses the cloud, and it stays there for 6 to 8 days. So then, and they're saying they have another one in WMR, but it makes it
Right.
really.
I don't have a good answer for you, but I mean, I know that's a concern. I mean, I think a lot of people are concerned about cloud storage, you just have to get there and all this.
Yeah, where I work, once you hear the word cloud goes in, it's like, well, not gonna stop it.
So I think we're in the infant stage of all this kind of stuff, right? We're struggling with cybersecurity, we're struggling with this stuff. I mean, I think people are finally getting better to where they don't have passwords taped to equipment, I hope. Maybe it's in the drawer now somewhere. I still got, we might run a little late, if that's okay. If you have to leave, I'm okay with that. I'm not gonna get offended. So medical equipment IT, majority of medical equipment purchased today can and reside on the network, wired or wireless, right? We talked about that. Equipment could be tied back to server, communicate in the cloud. I think HDM has a knowledge gap in IT education. I think probably most of you would agree with that. Well, then we need to up our game, right? We need to learn more about IT. And then since a lot of equipment existing medical equipment can be 10 plus years, you guys, I'm sure every hospital has equipment that's 15 years old, 20 years old, still running great. I was just in a talk a while ago about cybersecurity with legacy, and he actually made a good comment. And I hope people don't forget about this. I could have something 10, 15, 20 years old, and it's running Windows XP, but if it's not on a network, then it's not a security risk, right? Technically. So it's not a black and white thing. I understand how it's working, but this does create a cybersecurity concern, right? That's because now it wasn't designed or wasn't designed, it was designed in infancy. It's creating a concern. One of the things that IT did with us is, we did all the cybersecurity stuff in our CMS. We had all the MAC addresses and OS and all the other type of stuff in there. And they would want to know, okay, well, this is running whatever, Windows 7. What's it going to take to go to Windows 10? Well, they don't have a Windows 10 solution. Or what's it going to cost? And I think, and I finally just asked him, because it was going to take forever to do all this, right? I go, look, I know, let me just cut to the chase. I'm assuming you're trying to come up with a number, and if you can come up with a software solution, it's going to cost us $50 million to replace equipment, but I can buy a software solution for $5. That's what you're going to do. And I think that's what they were looking at. Does that make sense? Anybody right there? I understand the need to replace equipment, but now I've kind of learned there's also other ways to use legacy equipment, like the guy in the last session just talked about segmenting and doing some other stuff you can do so you can still use it and get your useful life, if you want to call it that, without totally replacing it. Again, it's not a black and white thing. It's running Windows 7, I got to replace it. If you would like to, by the time you get to 10, now 11's already out, right? So partnering with IT, it should be, to me, it's clear. I mean, IT manages network and they manage the security, right? Other than, and I've got a little caveat down here, some non-traditional IT components in a hospital, such as non-enterprise desktops and serial to IP. I don't know if people are still using serial to IP stuff. We used to use them on fetal monitors. We did, I think it was called Equinox. We would manage that. So it connected it to the network, but IT says that's not ours. You do it, so we did it. And I'm sure you guys have done a lot of stuff. Somebody says, I don't want to do it, you get it. So we did those. So that's not, again, that's not the black and white. You guys have followed Amy for a while. They come up with this gray list thing. We actually did a gray list thing decades ago because we were tired of engineering doing this or biomed doing this and nobody knew. So I just said, let's have a meeting, let's light out. Now, we never to do the IT thing, but you can say we need to have one for facilities, one for biomed, and one for IT on who does what. And it may differ by facility, and that way you can always go back to, well, you guys said you were going to do nurse call, or you're going to do beds, or you're going to do whatever, then that's how it needs to be, right? That helped us a lot by doing that. When it comes to biomed equipment, I would hope it makes sense that we should be doing cybersecurity, and then we should be doing the patching of that equipment, following the guidelines for that. We're going to work with IT and OEM to make sure that we have all the network drawings for your network, especially patient monitoring or wherever else you're doing out there. This goes back to what we were talking about a while ago. IT expects policies and procedures on downtime, escalation, and troubleshooting. In my experience in biomed, we just got it done. And when I got older, I kind of learned to appreciate what IT did this makes more sense. It gives people what the expectations are when I'm doing something. So how do you communicate downtime? Who do you communicate to? What's the expectations? How often do you communicate? Yeah, so here's an example. ICU patient monitoring is not communicating with the EMR. So here's your communication, right? You send an email out, the vendor's been called, should be on site by 8 p.m., right? That's your communication. And then you say, we're gonna start your EMR downtime, and then we'll notify you again the status. And the status could be 30 minutes or an hour, or whatever the expectation is. Not, well, he's not here yet, so there's no communication. They want an expectation. But one of the things I learned, and I had to have a CNO tell me this, is they're making decisions because something is down, right? They're bringing in more nursing, they're bringing in more staffing. Well, then once you told me that, it's like, okay, now it makes sense of why I need to communicate to me. I mean, I know what I'm doing, right? I know how long it's going to be down, maybe. The other thing I struggle with, well, I don't know how long it's going to be down because, well, I've got a vendor coming in and doing this. Well, but that's okay. Tell them it's down, do your backup procedures, and then I'll keep you updated when it's going. So that you know that the vendor's on site. He's working on this. He's maybe thinking it's going to be 5 hours, 2 hours. Then you tell them that, and then you follow up on a routine basis so they know until it's finally up, and then you can tell them and they can release their staff. That helped me once you kind of opened my eyes to what they were looking for. And you decide what's the best way to do it. Could be email, could be a conference call, could be a little bit of both. I was on tons of conference calls with IT when we had downtime and stuff. And people would come in and out of this. And if you've done any type of stuff with IT security, there's going to be some risk assessment form. And where I worked, we had a risk assessment form that was called a RAR, risk assessment report. It took me forever to understand what they were talking about, but it's basically you're figuring out, you're putting everything in a like a database of IP levels and MAC addresses and all the other type of risks that you have. You could argue it's kind of the same thing in MDS squared, right? Kind of the same thing. Risk assessment at your hospital is going to want this, and then IT obviously is going to want that, their risk department. But you know, there is a risk department outside of IT that's going to want that type of stuff. They're going to want to know what's going on. We talked about using MDS squared form from the OEM to help with that. I think they've just changed that recently. Of course, now there's some new stuff, the S-bombs and some other stuff that can help you with that. I would hope IT and risk management is routinely going to ask you what's going on, what are we vulnerable with, what stuff needs to be replaced. One, it could be because they're concerned about risk. One, they're concerned about how much it's going to cost me to replace my CTs or my patient monitor or something else, right? I think most people, I should have done this before. A lot of people think we need to report to IT. You know, that's kind of the new, we used to report to facilities forever. A lot of people started reporting to IT. I don't think it really makes a difference. I did, it worked fine, I think. I didn't, I think it worked fine also. You just have to know who you need to talk to, right? And so you need to know the security people, need to know the application people, and you need to know the project management people to communicate effectively and to share knowledge on when you're going to do something. Obviously, security, what's allowed on network, what OS you're working, IP patching, who does the patching, when is it done, what antivirus you're running, can default passwords be changed, and all this information should be in your CMMS, right? I mean, most CMMSs, I don't know if anyone doesn't allow that anymore, but you should be putting all that stuff in your CMMS. And then there are some cybersecurity programs you could buy that kind of theoretically auto-populate that stuff, right? We talked about this at the last meeting, is thumb drive security. Think about, I know we assumed that we had a piece of lab equipment infected by a vendor because they bought a thumb drive and probably do a patch or something, and it infected a network. I mean, this was a long time ago. Well, that's an easy way to do that. That's why people lock down thumb drives. I don't think the VA allows any thumb drive access anymore, right? Yeah, that's been that way forever. Most other people have done that too. We talked about this the last meeting, was physical security. Do not forget physical security. We all think, I think most of us think about cybersecurity and risk and all this stuff. Guys, people can just walk away with stuff, right? Physically, we had a laptop that was a ultrasound. It was stolen. Why? Because it looks like a laptop. So they're going to steal it. I haven't seen, and you could walk. I know we had a lot of desktop computers stolen in the hospital. Well, it could have been a central station, but it's a desktop computer. I'm going to steal it. Well, you need to think about physical security. I mean, literally physical security. Now, you can argue locking down thumb drives is physical security, but I'm actually talking about putting cable access, those cable locks on equipment. We did that for all of our central stations. Anything that had patient data, we physically locked them down. Or in our database, we actually said there's a physical security with this. And that physical security could be, there's a cable lock, it could be behind a door that requires badge access, right? Those are different levels of physical security. I would notate this in your database to show that, it shows how you're taking care of these things, because it's a big risk. I don't see that many people talking about physical security, but it is a big risk. And then what about unique accounts for each vendor? What about employees remote in, right? So a lot of us will have remote access, so FSCs can remote in and do that. You really need to look at how they're doing that. So if this one company has 5 FSCs and they all have the same sign-on credentials, that's not security. And what happens when the person leaves? Well, then their security doesn't go away because they're part of that 5-person team. It needs to be individual security for those people, and you need to know when that person is terminated that their rights are taken off your system to get in there, right? That's some pretty basic stuff. It's no different than what we have in the hospital. When you leave or you're terminated, all your security rights, you can no longer get on the network, right? You think about your outside vendors that are also logging in. There's a ton of cybersecurity resources that you can get out there, and you could probably Google and find a lot more than these. These are the ones that come from like Amy and stuff. There's a whole bunch more out there. And I think the one that the last class I just went to, he mentioned HICMA LTS. They just came out with a new 125-page document. I've got it written in my notes if you want to see it. That helps with cybersecurity with legacy devices, which I think most of us are going to have legacy devices. Definitely get to know your cybersecurity companies. You can learn more and more about what they're doing. They're always at the trade shows. I'll eventually go to the trade show where the vendors are in a couple of minutes to see what they're doing. There's always 3, 4, 5, 6, 7 vendors out there. Just get to know them, see what they can offer. There's a ton of webinars. TechNation to me is the best that's doing all these webinar Wednesday, right? Literally it's what, every other Wednesday, I would say 50% of them are cybersecurity. Watch every one of those because same thing, right? Doesn't come instantly. I've watched them as much as I can, and things eventually become more knowledgeable. One thing that I've learned, and I've kind of tracked this for a while, a good question. If I was a CNO, I said, well, or CIO, what's it going to cost me to put a cybersecurity solution on my medical equipment? I don't know. Well, that's when you find out. So get some vendors to talk to them. The last I've checked, and of course they don't want to give you a number. Now this may be changing. I think I've heard they're starting to change the fee structure. The fee structure used to be about $25 per device. So you could go in your database, how many pieces of equipment do I have that are on the network? Multiply by $25. It's an annual fee. There's your cost. Maybe that's a ballpark, right? You'll have a vendor come in and do that. Now I've heard some people sometimes there's some hardware costs that they have to put out there, but that's something you need to figure out from the vendor when you're talking to cybersecurity. But at least you can get an idea of what it would cost me to implement it or to buy it. And then the other advantages are sometimes that equipment will auto-populate. It's not automatic. There's still some work you got to do, but it will auto-populate some of that information back to your CMMS. And then some will claim utilization reporting, so they can see, well, this CT's only been used 3 times a day for the last week. Well, that's good data. We've actually had CEOs ask us that. Well, do I need a new CT, or do I have a CT somewhere in the system that's not being used? That's actually a very good question. This could help you with that. I did have our imaging director, he goes, well, I do know that my techs use the CT more than the users do. Well, that's not bad information either, but they're going to want something more concrete on how much, or how many hours a day are they using it. And then I've already talked about this. Don't forget about all the applications that are out there of how they're doing that and how do you handle a call when something comes in, especially nowadays. Holy cow. My patient monitor is not recorded to EMR. But who takes care of that? Well, the EMR team is this. Well, what if it's not an EMR problem? What if it's a patient monitor problem? Well, that's, again, the reason you guys need to understand IT and how everything works, how it's all connected together. and then how you can talk to somebody in IT in their knowledge to say, this is when we lose connection. Looks like it's on your side. Does that make sense? They're gonna, if you can talk to them in that language, they're gonna understand you better. Sometimes I think I was lucky, we had a PMO office when I was at Baylor. Well, if you're doing a big project, it's gonna take project management. Project management is a skill. I don't think as a biomed, you have to go out and get PM certified. If you have an organization that already has project managers, use their expertise. They don't have to be subject matter experts, right? They're a subject matter expert on managing a project, and that's what we did. We replaced all of our patient monitoring in the system. We got one of our PMs to help us with that. She was awesome. She walked us through the whole thing, right? She didn't have to know what patient monitoring was about work, but she could walk us through the way you do a project officially. It really worked out well. Concerns over going of age. A lot of people think we're just going to turn into IT. Things change. I mean, I've been in biomed, right? I said forever. Well, I was taught with vacuum tubes, if you guys know what those are, and those are, I think they're coming back, right? But I was trained on vacuum tubes, so I wasn't taught on computers, stuff like that. People have been in IT forever. Well, they worked on what they used to call it big iron or something like that. They worked on the big, huge, gigantic servers. Well, now IT, now you typically think of a desktop or just a desktop server or something like that. So things change. My brother's been in the automotive field forever. You guys, anybody have a new car? You open up the hood, can you even see your engine? I'm assuming, I've been talking even a gasoline engine. You open up the hood, it's like, I don't even know where the engine is. I mean, I know it's there, but there's literally the whole thing is covered with stuff. There's all kinds of electronics on a car now that a mechanic from 20 years ago wasn't being subjected to, right? So what can we learn? So to kind of sum it up, I think they have great policies and procedures, so learn from them. Steal, borrow, whatever you want to call it. Take some of them when you don't know what you should do. Well, then use some of their experience to build a policy, uptime, all that type of stuff that you can do. I think they're great at managing downtime. I was on lots of calls with them. Holy cow, they had that stuff organized. They knew who to call in, how to coordinate this, give people uptime or when stuff was going to work or not work. I think they're great at getting dollars for projects. I think biomed's always struggled with that. And they're good at being proactive to issues. I think biomed's always been historically reactive. Is it broken? I'll fix it, right? But you could argue PM is proactive, but not as much as what I think IT does. And so again, what I would do is look for IT to help with some of these issues. So not too bad. It's still 11 minutes over. If you've got questions or comments for me, I do have some business cards I can lay out if you want to pick up one. I do have a fun website, Tales of the Biomed, if you want to visit that and look at that. All these slides will be available probably in a couple of days or a week. They'll put them on the MD Expo slide. And those are some of the books I'm working on new. Tales of the Biomed Part 3, Incredible Tales of the Biomed, and I'm actually working on a book called Tales of the IT Guy. So those are some of my new ones I'm working with. And I told you about the QR code. I've never gotten these to work, but there is one in the back. You can scan it there. When you scan it, you're gonna have to put your name, who you work for, your email address, and you have to search for the presentation you're at, right? And then that's how you get your CE credits. And then I think you'll get a PDF document of your credentials, right? All right, I appreciate it, guys. Thanks for coming.